Welcome everybody to today's session. First of all, a disclaimer. This presentation is for information purposes only. Any advice or recommendation given in this presentation is not establishing any kind of professional relationship. So this information is to be used using your own judgment. I'm Dr. Dhiren Nanavati. I'm going to introduce the speaker for today on behalf of Dr. Srivastav. I'm sure you all have to deal with insurance issues in day-to-day life almost. And it almost feels like you have gone back to school again, to learn A, B, C, and D. So those kind of issues we face, and quite often the insurance business is a complex business. So today we have an expert in the field. We have Dr. Rajul Patel, who is a PhD in pharmacology, and he is at University of Pacific. Dr. Raj Patel is a professor there at the Pacific School of Pharmacy. He created their Medicare outreach program, which has had 168 events in 24 different cities across California. In total, the program has assisted 9,404 beneficiaries assisted with their Part D plan, collectively saving them $9.35 million. And that was their out-of-pocket prescription drug cost. Dr. Patel has authored over 150 peer-reviewed papers and presentations at national and international meetings surrounding the topic of Medicare. It is an honor and great pleasure on my part to invite Dr. Patel. Welcome, sir, and thanks for spending your time today.
Thank you, Dr. Nanavati, for that warm introduction. In terms of the agenda for today's talk, here's sort of a roadmap of what we'll be discussing over the next 45 or so minutes. So a little bit about an overview of Medicare, different parts, and I want to just share with everyone what the different parts cover, because it's crucial to understanding how the Medicare benefit works. And sometimes I make an analogy that Medicare is like an onion. The more layers you peel, the more you want to cry, because it's unnecessarily complicated. But hopefully after today's lecture, it'll be a little bit clearer. Most of the focus is, of course, going to be spent on the prescription drug coverage, Medicare Part D, and we'll talk about that and what that benefit is going to look like next year in 2022. And then it won't just be me talking. There'll be an interactive portion where I'll have different statements, and I'll want you to chime in as to whether you think it's true or false, and then we'll discuss why the answer is what it is. And finally, I'll share with you a little bit about our mobile Medicare clinics. And we have 2 events remaining in this season. One is a virtual event tomorrow, actually, and then we have one event in Lodi on Saturday. And so I'll talk about some of the services that you can expect to receive should you want to attend either of those events. So Medicare has 4 parts, as I just mentioned: Part A, B, C, and D. And Part A and B are often referred to as original Medicare. And the reason is because they have been around since the inception of Medicare in 1965. Way back then, Lyndon B. Johnson was president, and there's a historical photo that's taken where Lyndon Johnson is actually presenting the first ever Medicare card. And the figure to whom he was presenting to is President Truman. And it was at the Truman Library, and it was to recognize President Truman's extensive work in governmental health care. So first Medicare beneficiary was President Truman. The second one is actually his wife, Bess. Fast forward to today, and in our country, we have over 63 million people who have Medicare. So roughly 1 in every 5 Americans actually qualifies for receipt of Medicare. Part A and B have been around again for 5.5 decades. So let me spend a moment just describing a little bit more of what these 2 parts of Medicare actually cover. Part A, right? So most people who have Medicare, if they look at their red, white, and blue card, they will see Part A and it'll say hospital coverage, Part B, medical coverage. But Part A covers more than inpatient care receiving in a hospital. Yes, absolutely. If you are formally admitted to a hospital and you spend time in the hospital and you have Medicare, the hospital is going to bill Medicare Part A for that. But in addition to inpatient hospital care coverage, individuals who have Medicare that are discharged from a hospital to a skilled nursing facility and receive care in a skilled nursing facility are also going to receive some of those costs are going to be taken care of by original Medicare. Home health, this doesn't mean that anyone who has Medicare can decide to receive health care in their home. But if your physician determines that leaving your house requires extraordinary effort or can potentially jeopardize your health, then home health coverage would be covered under Medicare Part A. And then the last piece is hospice care, right? So this would be two physicians who independently, through their best medical judgment, determine that if your disease runs its normal course, you have less than or equal to 6 months to live. And in that case, hospice care, right, is palliative care. They're not trying to, at that point, cure the disease or really prevent its progression, but they're trying to make those last days as comfortable as possible for the patient who has hospice, who's receiving hospice care. Respite care is an unfortunately underutilized benefit. It is a phenomenal benefit. The roughly 63, almost 64 million people who have Medicare, about 85% of them are 65 and older. And if they're married, frequently their spouse is also an older adult. So let's kind of think about the scenario. I'm an older adult and I'm on hospice care and I'm married. So my wife is likely also going to be older. And so the primary caretaking responsibilities is going to fall to her, right? And that can be quite a burden, especially if we don't want to further burden family or friends. When is she supposed to go out and get groceries or run errands or get gas, right? That can be hard. I can't be left alone in many cases. So what respite care allows is the loved one who's receiving hospice care to receive such care in a Medicare approved hospice for up to 5 days at a time. So basically my wife can put me in a facility in which I'm going to receive all of the hospice care that's necessary for up to 5 days at a time. And during that time, she can take care of all of those household errands and needs that she needs to, with the comfort of also knowing that my care is being provided for, right? So that's respite care. So that's Medicare Part A. If you think about Part A as being sort of inpatient in terms of the types of care, then Part B is exactly the opposite. This is going to cover outpatient medical services. So you have Medicare and you want to see your doctor, your primary care doctor, for a routine medical visit. Part B is going to be billed. Or you want to see a specialist. Part B is going to be billed. If you receive any care on an outpatient basis, so let's say you go to an infusion clinic, you get your infusion, you come back home, they're going to bill Medicare Part B, as in boy. Medicare Part B covers dozens and dozens of preventative services, most of which are covered at absolutely no cost to the patient. So 100% of the cost of preventative services are typically covered by Medicare Part B. And then durable medical equipment. If you're like me and you like to watch TV late at night, sometimes you see those infomercials for like the Hover-Round or different types of motorized vehicles that people who have Medicare can actually use. Oxygen, nebulizers, wheelchairs, these are all considered durable medical equipment that would be covered under Medicare Part B. Aside from preventative services, most services that are covered on an outpatient medical basis under Part B, there's an 80-20 cost sharing. 80% Medicare will pick up, but that means the patient is responsible for the other 20% of the cost. So just a little bit about original Medicare. But as I mentioned, the majority of our time is going to be spent on the right side of the screen. Part C, Medicare Advantage plans, and then Part D, which is the Medicare prescription drug benefit. This is the newest inception of benefits to Medicare. It started in 2006, and so we'll spend most of our time talking about those. So Part C, you'll often also hear people refer to this, especially in the literature, in television and newspaper ads, and even on the radio, as Medicare Advantage. Okay, they mean the same thing. If someone says Part C or someone says Medicare Advantage, the two terms are synonymous with each other. Medicare Part C, you can only join if you have both parts of original Medicare. For some reason, if you only have one part of original Medicare, and there are some people who do, you cannot join a Part C plan. Okay, most people who have Medicare and have both parts of original Medicare have the option to join a Part C plan. The one exception has been individuals who have end-stage renal disease. So people who are receiving dialysis treatments or a kidney transplant, they have not been able to join a Medicare Part C plan. That exclusion is finally going to be removed starting January 1st of 2022, meaning no matter what your prior conditions are or your current conditions, doesn't matter if you have end-stage renal disease or cancer or diabetes or any condition, if you have both Part A and B, and you live in a county in which that Medicare Advantage plan is offered, they cannot refuse you the right to enroll in that plan. Okay, that's really a big benefit. These plans are not offered by Medicare. The way it works is they're actually offered by private insurance companies, but they're approved and subsidized by Medicare. And what I mean by that is, let's say you have someone who is enrolled in a Medicare Advantage plan. In San Joaquin County, Medicare pays that plan roughly $1,000 per member per month. Okay, so if I'm in a Medicare Advantage plan in San Joaquin County, that Medicare Advantage plan is going to collect about $12,000 in payments from Medicare for my care over the course of the year. Obviously, if I'm a low utilizer of medical services, I don't go to the doctor frequently, I'm not in the ER or the hospital, that plan is going to stand to make a substantial amount of money. Conversely, if I'm a heavy utilizer, right, I'm in and out of the ER and the hospital, then that $12,000 is not even going to partially offset my cost to the company. But that's how insurance works, right? That risk is borne by the insurance company. So the way I like to think about Medicare Advantage plans is by this simple formula. A plus B plus or minus D equals C. So what do I mean by that? Medicare Part C at minimum has to cover all of the benefits of Part A, all of the benefits of Part B, and in most cases, these plans will also offer prescription drug coverage. Not always, and that's why I have plus or minus D. So I like to refer to these plans as a burrito plan because they nicely wrap up all of the different benefits of Medicare into one nice package. And that takes us to Medicare Part D. D for drugs, okay? Again, this started in 2006. It's the first time that people who had Medicare actually had prescription drug coverage for their outpatient medications. Prior to 2006, if you had Medicare, you either had to get private insurance or you had to pay out of pocket for your prescription drugs, both of which were quite costly. And this finally changed in 2006 with the inception of the Medicare Part D benefit. So this is a benefit in which most people who have Medicare are not automatically going to be given this coverage. They have to choose and actively enroll in a drug plan. And I want to be clear, these plans offer prescription drug coverage. Okay, they don't offer over-the-counter drug coverage. It's only for prescription drugs. If you have Medicare, your first fork in the road in terms of how you can get your prescription drug coverage is the following. You have two primary options. You have the Medicare Part C plans, or those Medicare Advantage plans we just talked about. And sometimes you'll refer to these by the acronym MAPD. MA stands for Medicare Advantage and PD stands for prescription drugs. And as we said, these will cover all of the A benefits and the B benefits, and in this case also include the Part D benefits. And as we also mentioned, you need both parts of original Medicare to be able to join such a plan. The other way you can get your prescription drug coverage is through a standalone prescription drug plan, referred to by the acronym PDP for prescription drug plan. Here, it is what it sounds like. It's not going to offer any health or medical coverage. It's simply going to offer prescription drug coverage. And for this, you don't need both parts of original Medicare. You can have one, or you could have both, and you can sign up for a PDP. Now, it would be great if the option was as simple as this. I just had to choose, do I want an MAPD or a PDP if I'm a Medicare beneficiary who wants prescription drug coverage? But it's never this easy with Medicare. So once you choose which route you want to go in, then there becomes a lot of different plan offerings. Medicare Advantage plans differ depending on what county you live in. Why? Because if you think about it, remember I said these plans offer medical, hospital, and prescription drug coverage. So you need a physical brick and mortar building to go to receive care, right? In San Joaquin County, we will have 29 different Medicare Advantage plans from which to choose in the year 2022. You can see San Francisco has fewer plans because it's more densely populated. If you get to LA County, if you live in anywhere in LA County, Medicare beneficiaries have 70 different Medicare Advantage plans from which to choose. And I'm going to sound like an infomercial, but wait, there's more, right? Because we said you also have the option of selecting standalone prescription drug plans. These plans vary depending on what region you live in. And again, I don't know why Medicare makes this so complicated, but they take the 50 states in the country, they're divided into 34 regions. meaning that some regions are actually comprised of more than one state. Okay, California is not one of them. We are our own region. But what that means is whether you live in Stockton or Dublin or San Francisco or San Diego or LA or anywhere in California, next year you will have 25 different standalone plans from which to choose. So let's just think about this for a moment. If you live in San Joaquin County, you will have 54 different ways to get your prescription drug coverage through Medicare next year, right? You have 29 Medicare Advantage plans and you have 25 standalone plans, right? Most of us during our working years maybe have 3, 4, 5 health plans from which to choose from our employer, and that can be overwhelming. I know we just did our open enrollment at the school and it took me one full day to figure out which plan I wanted to go with for my family. I can't imagine having 50, 60, 70, 80, LA County, 95 different ways to get your drug coverage. So a quick overview on what we've talked about. Medicare patients have 2 primary routes by which they can get coverage. The route on the left, they have original Medicare. Sometimes these individuals will add something called a Medicare supplement or a Medigap policy. And it is what it sounds like. It helps fill the cost of what original Medicare doesn't pay for. And then they can add the Part D standalone prescription drug plan. The other way you can get coverage as a Medicare beneficiary is those Medicare Advantage plans. And so you might be wondering, which one makes sense? Which one would you recommend? Which one do people choose? Let me just tell you a little bit about how this works. It's about a 60-40 split currently. 60% choose the route on the left and 40% choose the route on the right. So why? What would be some advantages of each? Well, if you want flexibility, you have particular doctors that you like to go to and particular places through which you want to receive your care, then you're going to have the most flexibility choosing the route on the left, because you can go to any doctor or any facility that accepts original Medicare. And almost everyone does, because think about, you have 63+ million people. You can't say we don't accept Medicare patients, right? That could take out a big swath of the population that you could otherwise serve. Then what is the advantage of the path on the right, the Medicare Advantage plan? Well, one of the disadvantages, of course, is it's restricted in terms of networks, right? You can't go to any doctor. You can't receive care from any facility. You're bounded by networks. Who's in the network? You can go to those individuals. If you choose out-of-network providers, you may be responsible for 100% of the cost. Okay, then why would I want to join that? The primary reason why people join a Medicare Advantage plan is because it often covers benefits that original Medicare doesn't pay for. And the 3 that are most important to older adults are vision, dental, and hearing. Original Medicare does not cover those services. Okay, so if you choose the route on the left, you're not going to get coverage for hearing, preventative or comprehensive dental care, or vision. But if you choose the route on the right, most Medicare Advantage plans cover 1, 2, or all 3 of those benefits and other benefits. Some of them cover transportation benefits, where they'll literally pick you up from home and take you to a doctor visit or take you to the pharmacy to get your meds. So that's really the balance that you have to weigh when selecting what plan is best for you. Do I like flexibility? And is that primarily the most important factor for me? Or am I willing to sacrifice flexibility to get some of these additional benefits? This next slide, I will promise you and preface this by saying it's going to get complicated, a lot of numbers and a lot of jargon, but there is a punchline. So just stay with me until I get to the punchline. But no matter how much you spend in the previous year with regards to drug costs under Medicare Part D, on January 1st, it resets to 0. Okay, and the number that you're going to see being populated here is total drug costs. So this represents not only what the patient pays, but also what their Medicare drug plan pays. And so this is being kept track of all throughout the year. Right now, you basically see gray or black on the screen, but in a moment, you're also going to see yellow. And as you can see, the gray or the black represents what the patient's responsible for out of pocket. And then the yellow is going to represent what is covered for the patient through the Medicare drug plan or through a pharmaceutical manufacturer. So in 2022, the standard benefit is such that there's a $480 deductible. Now, notice there is no yellow, right? Because with the deductible, the patient is 100% responsible of the cost in that window. So any drug cost between $0 and $480 would be the patient's responsibility. This is the maximum allowable deductible, meaning nowhere in California, nowhere in the country would Medicare approve a drug plan in which the deductible exceeds $480 next year. Once you get to $480, all the way up to $10,000 $12.50. Now you're looking at a 75%, 25% cost sharing. 75% of the cost during this window are picked up for the patient, but that means 25% of the cost are their responsibility. Okay. And then once you get to $10,000, $12 and change, and any drug costs which exceed that amount, you are now in the fourth and last phase of the Medicare benefit. It sounds terrible, but it's actually the best place to be. It's called catastrophic coverage. The reason it's the best place to be is the patient pays roughly 5% of their drug cost. Okay, so the smallest sliver of their drug cost are they responsible for during this phase. Now, again, a lot of terms, a lot of numbers. Why is this important for me to share? Let me kind of explain to you why I think this is important. I have patients all the time. They go January, and let's say they're taking a $100 medication. And they go in January to the pharmacy and they get the medication filled and they're charged $100. And you fast forward to June of next year, and that same $100 medication at the pharmacy is now $25. And you fast forward to November of next year, and that same $100 medication is now $5. And they're wondering what's going on. I'm taking the same medication written by the same doctor, filled by the same pharmacy, and under the same Medicare drug plan. And in January, I was charged $100, and in June I was charged $25, and in November I was charged $5. Why? Because what's happening behind the scenes is the Medicare drug plan is determining which of these four phases of the benefit you're in. So in January, you were in the deductible phase, and your $100 med, you pay $100 for. And in June, you were in the middle phase, and you're responsible for 25% of the cost. So that $100 medication, you pay $25 for. And fast forward to November, and you're responsible for 5% of the cost. And therefore, the $100 medication, your responsibility of that is $5, right? So it has nothing to do with the pharmacy charging more or less or making a bigger profit. It has everything to do with what phase of the benefit you're in. It's important to understand not only if a drug is on formulary, which is great. It means it's on the list of covered medications, but it's also important that you understand if the drug plan has any restrictions or utilization management tools surrounding any of the medications that you're taking. So what do I mean by that? What are examples? Prior authorization. Okay, what this means is simply that the patient and or the prescriber must make sure that the patient satisfies certain criteria before they're going to get access to a particular medication. The drug is on the formulary, but I can't just get it without ensuring that I fulfill certain criteria. Okay, and here's just a couple of examples. Prolia is a drug that's used for osteoporosis. Okay, this drug plan has a prior authorization, and you can see what the exclusion criteria is. If a patient is also taking other medications for osteoporosis, and you can see here bisphosphonates like Fosamax, raloxifene, calcitonin nasal spray, any of those medications, this drug plan will not enable this patient to get their Prolia. Okay, if they're taking just calcium and vitamin D, that's not a problem. So it is important to understand if you can fulfill these PA or prior authorization criteria. Step therapy is another restriction. Okay, with many disease states, there are multiple classes of medications that can be used to treat the disease. Blood pressure, cholesterol, diabetes, there are several classes of medications. What step therapy says is, look, we understand that you and your prescriber want you to get this particular medication, but that medication is usually more expensive. And so before we give you that, we want you to try some other medication, which is also used to treat the same disease state that is typically much lower in cost. And if you try and fail that, or you don't tolerate that, no problem. Then you can get this more expensive drug that you and your prescriber want you to get. And that's what step therapy is. Okay, so you can see here a couple of examples. Febuxostat, this is only going to be covered under another plan if the patient has tried oral allopurinol. And you can see at least in the PA criteria, at least 30 days in the last 6 months. And the other ones, sulfenacin and tolterodine or tolterodine ER, which are different medications for incontinence. The coverage will only be provided, you can see if certain drugs, again, have been tried at least 30-day supply in the prior 180 days. Again, if you don't satisfy these step therapy requirements, for all intents and purposes, you're going to have a difficult time getting access to the medications, and the prescriber is going to ask for a formulary exception and go through that whole process, and it can become quite cumbersome. The third and last type of restriction I want to talk about is a quantity limit. And this one's the easiest to understand. It basically just means you can get a certain amount of a medication over a certain period of time, right? So if the quantity limit is 60 tablets per 30 days, and you only take 1 tablet a day, this is a non-issue. You only need 30 a month, it's not a problem. But what if you take something 3 times a month, 3 times a day? You need 90 tablets a month, and the quantity limit is 60 tablets per month. Now we're talking about an issue, right? Because you need the medication at a higher amount than the quantity limit for the plan. So ultimately, what I'm hoping you get from today is that every Medicare drug plan, and this is a lot of this actually applies to non-Medicare insurance plans as well, but they have different premiums. There are Medicare plans in our county, San Joaquin County, that have a $0 monthly premium next year, and there are plans that have a monthly premium in excess of $100. Deductible, there are some plans that are charging no deductible for next year. Some are charging an intermediate deductible, and some are charging the maximum allowable deductible of $480. Cost sharing structure means how much you're asked to pay for your medications, and that can differ between plans. Co-insurance is if you're asked to pay a certain percentage of the drug cost, and a copay means you're asked to pay a certain dollar amount that's typically dependent on what tier the medication's on. Formulary, every drug plan is different. Medicare has some minimum requirements in terms of formulary coverage, but plans have a lot of flexibility as to what they want to cover. And so you need to make sure that your medications are covered under that plan. Pharmacy networks are increasingly becoming an issue because all plans don't accept all pharmacies don't accept all plans. And sometimes not only will a pharmacy accept a plan, but there's things called preferred pharmacies versus a standard network pharmacy. And it's important to go to a preferred pharmacy because your costs are going to be the lowest, right? And pharmacies don't know if they're preferred or not because they contract with so many different plans. So you have to do some homework on these kinds of things. And drug restrictions we've talked about. So a lot of different factors go into this. Medicare Part D is a wonderful benefit. Don't get me wrong. For over 90% of people who have Medicare, their out-of-pocket costs are lower through Medicare Part D than without it. But despite the fact that this benefit has been around for now 16 years, there still remain challenges in terms of accessing the benefit. Number one, we've talked about how many plans are offered. Where can individuals go to get objective, unbiased information, right? Not where someone's trying to push them in a plan or someone's trying to steer them into a plan, but where they can actually get someone who's working in concert with them to find the best plan. Too many choices, I think we all like choice, but do we need 40, 50, 60, 70, 80, 90 plus different drug plans, depending on where you live in California? I think that's just excessive. And I think many of you would probably agree. Literacy, I'm not saying, are you literate in English, but Medicare has its own language. Terms like creditable coverage and catastrophic coverage and the coverage gap or donut hole. And it's important to understand the terminology, because if you don't, oftentimes you can make a wrong turn, and that's going to oftentimes result in higher than necessary out-of-pocket drug cost. And then language, though not perhaps a limitation for anyone on this call, about 10% of all Medicare beneficiaries reside in California. Okay, so almost 6.4 million people who have Medicare reside right here. Many of them, English is not their primary language, right? So where can they get access to information to make an informed decision? And then there's other issues. As you can see, the Medicare Plan Finder tool is a wonderful tool, something that we utilize, but you need a computer and internet access, and then you need to be able to navigate the tool. There's several different screens of information that you have to enter before you get to the pot of gold at the end of the rainbow. And even then, the information is not easy to understand, regardless of your level of formal education. Other challenges beside just the number of plans, we've talked about plan parameters and design attributes vary. We're right in the middle of Medicare open enrollment. This is the time when people who have Medicare can switch their drug plan for the upcoming year. If you've ever tried to call 1-800-Medicare during this time, I hope you're really patient, because it's likely going to be a substantial amount of time before you get a live operator. So it's kind of like that Snickers commercial, not going anywhere for a while, grab a Snickers. Make sure you have your iPad or something handy so you can distract yourself as you're waiting on hold. And then extra help or low income subsidy. This is a benefit for people that don't quite qualify for Medi-Cal. So that would be people who are low income, but they can still qualify for additional governmental assistance to help offset their medication costs. And unfortunately, still people are not aware of this benefit. So ultimately, the bottom line from all of this is suboptimal plan selection. What do I mean by that? So we have had our Medicare program at the school for 15 years. And as part of that, we always collect data and have collected data from the first day. And what we have found in the 9,500 nearly Medicare patients we've assisted prior to this year is that about 75% are paying more than they have to for their medications. I'm not telling them to change their medications. I'm certainly not telling them to change their doctors. I'm simply saying by changing the insurance provider, roughly 3 out of 4 every year can save money. And it's not an insignificant amount. It's about $985 per person per year, right? So you're looking at an extra $82 in their pocket. And that's not a small amount when you consider most of these individuals are older adults. Many of them are on fixed income with limited resources. This is money right back in their pocket that they can use for some other purpose. So here's the interactive portion. What I'm going to do again is just have true false statements. You can shout it out, you can type it, whatever you want to do, but I want you to tell me whether or not you think the statement is true or false, and then we'll reveal the correct answer. So the Part D open enrollment period is between October 15th and December 7th.
Correct.
That is, I see a few of you have chimed in and written in, and that is correct. This is the 7-week window when anyone who has Medicare can actually make a switch to their drug plan, and that new plan would take effect on January 1st. So, you know, many of us think about going to the doctor for an annual checkup. I tell Medicare patients the same thing. You have to think about this as an annual checkup period for your drug plan, making sure that it's still going to be the plan that best suits your needs in the upcoming year. And here we are, open enrollment, October 15th to December 7th. So there's a lot of different times that people who have Medicare can join a drug plan. But this is available for anyone, this window. Next one, if I'm happy with my drug plan, I don't need to check it during the open enrollment period. True or false?
False.
Yeah, this one absolutely is false. If you're happy with your drug plan, that's great. But you still need to check your drug plan because plans change. Every year, you might have a plan that has a relatively low monthly premium and they'll change it. And you see this, I'm seeing this year, where one of the plans that has a roughly $28 premium this year is going to over $80 next year. Plans will change their deductible. They'll change their formulary structure. They have to inform you, and they do. They send a booklet with all of the information, but that booklet is like a telephone book. No one's going to sift through that and look at all of the changes. No one has that kind of time. And they prey on that. They know that most people are going to squat and stay in their plan. And then you go to the pharmacy in January, and now your copay is much higher, and you get the first statement and your premium is much higher, and you're stuck, right? Because you didn't take the time to reevaluate if that plan was going to be the best for you. My out-of-pocket drug cost under my Medicare drug plan can vary depending on the pharmacy I go to, right? True or false?
It depends on the plan, not the pharmacy.
Right, exactly. So this is going to be true in terms of every plan has a different pharmacy network, right? So you need to know two things. Not only A, is my pharmacy in the network of my plan? That's good. But the second thing is it a preferred pharmacy or a standard pharmacy? Next one, premium is the primary factor I should consider when choosing a Medicare drug plan. What do you think? See someone in the chat box put false? Yeah, this is false. Premium is one factor, okay? Most Medicare patients choose a drug plan based on two factors, premium and deductible. And plans know this. So plans will try to offer a very attractive plan with a low monthly premium, hoping that many people join it. But premium is just one factor, right? Because you also have to consider things like how much am I expected to pay at the pharmacy when I get my medications? How much am I expected to pay during the deductible phase, right? So there might be a higher premium plan, but when you actually look at the full out-of-pocket cost, all in, that higher premium plan may actually save a patient money over the lower premium plan. So don't get lured into this trap. My Medicare drug plan will cover any vaccine I need or want. True or false?
I think that is true.
True.
All vaccines are
True.
covered.
So it's all vaccines are covered is true, but the Medicare drug plan does not cover all vaccines. Let me explain how it works with vaccine coverage under Medicare. Okay, Medicare Part B as in boy. Remember I said that they cover a host of preventative services. A few preventative services included under that are vaccines, and specifically the annual flu shot, pneumococcal vaccine, right? And there's two different pneumococcal vaccines. Both are covered under Medicare Part B. Hepatitis B vaccine, which is a 3-dose vaccine series for most people for medium to high risk patients, including patients who have diabetes and end-stage renal disease. They work in an occupation in which they're exposed to blood and bodily fluids. There's several other risk factors that would determine someone is at medium to high risk. That would be covered. And the fourth one is the COVID vaccine, all of them. These 4 preventative vaccines are covered under Medicare Part B. And remember, almost all preventative services, including these 4 vaccines, are covered at no copay. So if a patient wants their annual flu shot, whether they go to the pharmacy or the doctor's office or anywhere, if that provider is billing Medicare Part B, there is no cost to the patient. It's 100% picked up on their behalf. Every other vaccine that's available in our country is covered, but it's covered specifically under the Medicare drug plan. So if you talk about the tetanus, diphtheria, whooping cough vaccine, Tdap, or the shingles vaccine, Shingrix, or hepatitis A, or any other vaccine, it's under Part D. But here's the big difference. With Part D vaccines, there's almost always a copay, right? So patients will come to the pharmacy and they'll get, their flu shot and there's no copay, and then they want the first dose of the Shingrix shot for shingles. And you run it through the insurance and they get an $85 copay, and then they're upset because they think, why is my insurance not paying for that? Well, no, it is, because the full cost of the shingles vaccine is just about $200 a shot. But what they're not accustomed to is having to pay a copay, right? So that's something, it's a point of education that I try to make with patients, is that all vaccines are covered. If it's specifically a Part B vaccine, you will have no copay. If it's a D vaccine, you almost always will have a copay. Okay. And then lastly, the answer is here, so you don't have to worry about it, but there's no one to help me review my Medicare drug plan. And honestly, when I started the program with a couple of colleagues 15 years ago, this was our intent. We identified that there was going to be this wonderful benefit, but it was going to be complicated. And what we did was we decided to build a classroom to the community model, where we train students over the course, pharmacy students over the course of 2 semesters, but then they take their knowledge and directly go into the community and assist people with Medicare in terms of optimizing their drug plan. And so this year, during this open enrollment period, we have 11 events, 7 in person and 4 virtual. We are down to our last weekend of events. As I mentioned previously, we only have 2 events left, one tomorrow, which is a virtual event, and one on Saturday, which is an in-person event. The virtual event, right, and actually at both events, the core services that we can provide is we will assist with the Medicare Part D plan. We will sift through the options based on your medications, based on the pharmacy you like to go to and other personal parameters, and identify the lowest cost drug plan. And if you want, we can even take care of enrollment right there on site, so it's completely done for you before you leave. The other service we provide is called medication therapy management. And it's just a fancy term that means a comprehensive evaluation of all of your medications, prescription, over-the-counter, herbal supplements, to ensure that they're safe and effective to take together. Okay, so those are the core services. It can be done virtually, like we're doing today through Zoom. That's what we're going to be doing tomorrow. Or it can be done in person. In the in-person events, we have additional services that we're providing. Immunizations. So we will have a variety of different immunizations, the flu vaccine, COVID vaccine, and others, those that are billable to Part B and also those that are billable to Part D. Diabetes screening, blood pressure testing, cholesterol screening, and bone mineral density testing. Those services will be provided. Narcan. If you're not familiar with Narcan, Narcan is the antidote for an opioid overdose, right? And the reason this is critical for us is in our county, there are 2 populations at highest risk for an opioid overdose, both of which were surprising to me, when I found out. One is pregnant women because they're injecting heroin, and the second are older adults. Oftentimes because they're taking other medications that put them at increased risk for respiratory depression, like benzodiazepines, drugs that are used for anxiety. And so what we provide is Narcan and consultation as to how to use it and signs and symptoms of an opioid overdose. COVID vaccine and testing will be available as well. And then drug take-back envelope and sharps containers. Let me just talk about that for a moment. The envelope is what you see on the bottom of this picture on the right, and it is for any unused, unwanted, or expired medications. So if you have any medications at home and you want to properly dispose of them, including controlled substances, including drugs like opioids, you can put them in this envelope, seal the envelope, is postage prepaid, and they will be properly disposed of by the preferred route, which is incineration. But let's say you use a medical sharps. Let's say you're injecting insulin or some other medication, right? And you have all of these syringes and you don't know how to properly dispose of them. We will also give the medical sharps container a picture, the top part of the picture as an example. And that pamphlet that you see in the middle of that sharps container is actually all of the different locations in our county that actually you can drop off the sharps container. Okay, so that way it's easy for you to know where to drop it off. All of the services that I just mentioned are completely free of charge. You can take advantage of any of these services or all of these services, and you won't have to pay anything. It's part of our community outreach program. Let me talk a little bit more in detail about the medication therapy management so you can kind of see what you can expect to receive should you want to take advantage of this. So a few years ago, the American Medical Association wanted to conduct a study and they wanted to identify the top reasons that people are not adherent to their medications. Why are people not taking the medications that prescribers prescribe? And here are the top 5 reasons. Fear, misunderstanding too many meds, lack of symptoms, and cost. Right? Fear stemming from maybe they have a family member or friend who took a similar medication and they saw the side effects and they don't want those side effects, and so they forego taking their medications. Misunderstanding, not understanding exactly what the medication is for or what to expect from the medication. Too many meds, especially older adults. The average patient that we see at the Medicare health fairs, 6 prescription drugs and 3 OTC drugs. But we see patients who are taking 20 plus medications regularly, right? You can imagine your whole day will probably revolve around just medication schedules, when to take what drug in that case. Lack of symptoms, there's still this misconception that if I don't have symptoms, I don't need the meds. For diseases like hypertension or high blood pressure, it's a silent disease. Most people who have high blood pressure, they don't have overt signs of having high blood pressure. So you can't just take your blood pressure medication when you feel that your blood pressure is high. It doesn't work that way. And then cost is the primary barrier to medication adherence. Physicians will write medications. They might be the ideal medication for that patient, but when they go to the pharmacy and it's run through the insurance and the copay comes back at $150, guarantee you not everyone's getting that medication filled, right? And so then they're out of that, they're not taking that medication, and of course that can impact their health. So as part of the services that we provide during this medication therapy management, it's everything that you see on the screen here. And I want to specifically highlight 2 services: the personalized medication record and the prescriber communication, or to promote coordinated care. This is an example of what we will provide you. So we have all of the medications that you're taking, and simple language. You can see losartan, take by mouth for high blood pressure. We also have a pictogram. So based on the sunrise or the sun at high noon or the sunset or the moon, you can see the optimal time of day to take your medications. And on the bottom, you have your as needed medications. So these are not routinely taken, but we also indicate, when you need to take them and how to take them if you do need to take them. The nice thing is, with a simple click of a button, everything that you see here that's in English can be converted to one of 26 languages, okay? So we can convert it into a variety of different languages. Hindi, Gujarati are currently not one of them. But there's other languages that we frequently use for some of our events that have that are serving racial and ethnic populations. Cantonese and Mandarin, very common. Vietnamese, Tagalog, and Spanish. Those are our 5 most common languages. In addition to the personalized medication record, we also provide individual drug monographs. So if anyone here has recently gone to the pharmacy and picked up a medication, with it comes a piece of paper called a monograph, right? If you've read that font, it is small. I know I have difficulty reading it. It's written at a 12th to 14th grade reading level, which means high school senior to second year of college, not a lot of white space on the paper, so it makes it difficult to read. And frequently, you can't translate that into any other languages. The pharmacy can't. We have a program in which this is an example of a patient monograph. You can see that a lot more white space than a typical drug monograph, so it decreases the eye burden. It's written at on average of 6th grade reading level and no higher than an 8th grade reading level. So it makes it much more accessible to people in terms of understanding their drug information. This too can be converted into one of 26 languages. And you can see it also has the pictogram. So you know about when to take your medication. So this would be provided should you want it. And as we're doing a med review, let's say we identify a severe medication related issue. Maybe it's a severe drug-drug interaction, or potentially you have unnecessary drug therapy or duplicative drug therapy. With the patient's permission, we will fill out what you see on the screen here, which is our prescriber communication form. On the left-hand side, we will identify the possible medication-related issues or issues. So it might be one or multiple boxes. In the comments section to the right, we'll provide a little bit more narrative to help the prescriber understand what we found. And then we also provide a recommendation, a suggested recommendation for the prescriber to consider. It might be adding a med, discontinuing a med. There might be a cost-saving alternative, which a different drug will achieve the same outcome, but at a reduced cost for the patient and therefore improve their adherence. And then we will type this up. This will get faxed to the provider. And then we also follow it up with a phone call within a couple of days to see if the prescriber has any questions and also to see whether our recommendation was adopted. So again, just 2 events remaining. You can see here tomorrow's event, the one that's in gray is a virtual event. If you want to take advantage of the events, the phone number you probably don't want to call now because it's after business hours. You can still email us at that Medicare Clinics email. We're going to be checking it all the way until midnight. Our event starts at 10 a.m. tomorrow. And there's still appointment slots, especially later in the afternoon after 2:30. Everything prior to that is pretty much jam-packed. But remember, at the virtual event, we can only do the Medicare review and the medication review. If, in fact, you live close by Lodi and are willing to come, you can come take advantage of all of the other screening services I mentioned, and they will all be provided at the Lodi event. That's on Saturday, so you can call and make an appointment tomorrow at the phone number that you see there. And just so everyone knows, we will have and have had an abundance of safety precautions in place. I understand fully that almost all of the people who attend our events are 65 and older, and they're obviously at increased risk for some of the most severe complications from COVID. So we are exceeding both local public health and CDC guidance in terms of what we do. There are very detailed safety protocols in place. One of which is if you want to attend, one of the requirements is that you provide proof of the initial series of the COVID vaccination. Okay, every person that you're going to see there is in the same boat. All of the pharmacists, all of the community volunteers, every pharmacy student, we have verified that that's the case, and we have to do that with the participants as well. And just so you know, some of the other safety protocols, the students are triple layered. They're wearing a surgical mask, they're wearing a cloth mask, and also a face shield. Pharmacists are double masked. We don't eat or drink anywhere in the healthcare setting. Everything has to be outside, so no one's removing their mask. We clean every table after every patient with alcohol wipes and disinfect the laptops, the desks, the chairs. And those are 3 of 12 different safety protocols we have in place. Here's just, again, more information about the Lodi event. If you want, I should have mentioned this earlier, if you want to come to the Lodi event, and you specifically want the Medicare review or the medication review, please make an appointment, because those services take about an hour to an hour and a half to complete, right? And if you don't make an appointment, we'll do our best to serve you, but it could be hours before you're seen because we have to take appointments first. If you just want to come for some of the other screenings, you want your bone density checked, or you want your flu shot, or you want to check your hemoglobin A1C for diabetes, there is no appointment necessary. Those are walk-up services. The turnaround time is typically minutes. It's not a problem at all. But specifically for those core services, please do make an appointment. And with that, oh, I do have the safety protocols in case anyone's interested. So here are, again, there's, I think 13, 14, 15. We have 15 safety protocols. I'll just leave this up here just so people can see some of them. But during this, I'll be glad to answer any questions that you might have for me.
So, Dr. Patel, I must say that this is by far one of the best and most informative sessions we have had in a long time.
Thank you.
Your presentation was excellent, clear, concise, and very informative.
Thank you.
I especially would like to commend you and University of Pacific for your community outreach program. I think it is one of the unique programs, and I'm sure community would benefit a great deal from it. I have one question.
Please.
You gave an example for a medication. If somebody has a deductible of $480, which is the most that can be charged,
Right.
and you say that in January you pay 100, in June you pay 25,
Right.
and in November you pay 5 for same medication.
Correct.
So does not that take into consideration the total deductible of 480 per year?
Right. If great point. So that's under the assumption that's not the only medication you're taking. I was just giving, if the patient is taking several medications, right?
I see.
And then one of them costs $100, then yes. But if that's the only medication, you're right. Then if those are the times of year that they get it, they would still be paying $100 because they haven't met their deductible, right?
Okay. Thank
Yep,
you.
of course.
Anybody else?
Yes, we have a question from Sharad.
So at one point they had this donut hole
Yes.
mechanism in Medicare Part D. Is that
Yes.
still there? And can you explain that a little bit?
Absolutely. So great question. So the donut hole, it's an affectionate term that's kind of a misnomer. Let me just give you, since you asked, look, historical background. What happened during the first 3 years of Medicare Part D? 2006, 7, 8, and 9 was slightly different. But what happened was once you reached the deductible phase and after the second phase, which is called coinsurance, you would hit this donut hole. And what it meant was Medicare was basically saying, we're paying a big donut. 0% of the drug costs. Patients 100% responsible for the drug costs through the donut hole until they reach that fourth and last phase called catastrophic coverage. And that happened again for the first few years. And quickly what Medicare realized is, oh no, when people were reaching the donut hole, what do you think happened? You know what happened? People were not filling their medications because now I can't afford $500 for my medication, the 100% of the cost. And then what happened? Now they went into the ER. And they would get hospitalized because they couldn't afford their medication. So Medicare looked at this and said, oh my goodness, as we look at the claims, the Part A and Part B claims for people when reaching the donut hole, they were disproportionately higher than people that were not in the donut hole. And they said, this doesn't make sense, right? We would save a considerable amount of money if we help offset the cost of medications in the donut hole. We would more than save it on the Part A and Part B side. So in 2010, they offered a one-time cash rebate if you reach the donut hole. And then starting 2011, they actually subsidized a percentage of the cost, such that now in 2021, and 2022 is going to be no different. If you reach the donut hole, and you'll see sometimes this referred to as closing the donut hole, it's not really closed, but patients are responsible for now only 25% of the cost of medications. As long as it's on formulary, it doesn't matter if it's a brand name medication or a generic medication, they pay 25%, the other 75% is picked up for them, right? Far better than the 100% they used to be responsible for. So that's how the donut hole is.
Great.
Thank you.
Yep.
If you have any questions, please unmute or chat. You can also type it in the chat box. Go ahead.
While waiting for others to ask, may I ask one more question, please?
Please.
Is it allowed for a person to switch between original and Medicare Advantage plan as per their desire? Can you do it every year, or can you do it every 2 or 3 years?
Absolutely. So anytime you have, if you, first of all, to be in a Medicare Advantage plan or to consider joining one, you have to have both parts of original Medicare. But let's say this year I'm in a Medicare Advantage plan. Kaiser is the best example. And then next year I want to switch to original Medicare and drop Kaiser. And then in 3 years, I want to go back to another Medicare Advantage plan. You can absolutely go back and forth should you want to. Those decisions typically have to be made though during this open enrollment period, October 15th to December 7th.
Nice.
So you're not stuck in just one pathway. You can go back and forth.
Thank you.
Yep.
We have in the chat box a comment from Fatima. Her husband was also cardiologist at Kaiser. He's retired, and she's thanking you very much for a very informative session.
Most welcome.
And I had a question earlier. I know you mentioned copay for the vaccine.
Yes.
And I was just curious, how much would be a copay for a shingles vaccine on Part D?
Yeah, it depends, right, on a couple of factors. Number one, what phase of the benefit you're in. So let's say you're healthy and you haven't had one medication filled all year, and your plan has a deductible, you're going to be responsible for close to $200, the full cost of the vaccine. But it's going to be dependent on two things: the phase of the benefit you're in and the Part D plan. Most times, if they've met their deductible, most copays for shingles, usually I see somewhere between the $65 to $85 range. That's the most common, but there's quite a bit of flexibility. Some will be less than that even. For example, if people have Medicare and Medi-Cal, they'll pay far less than that for their vaccine, because what Medicare doesn't pay, Medi-Cal picks up the majority of. And then again, if they're in the deductible phase, they'll pay 100% of the cost.
Thank you. And then I see a hand raised by Moise Beguwala. So please go ahead and ask your question.
Yes, Dr. Patel, thank you very much for really good information. I have a very specific question. I have Medicare Part D with WellCare. What I run into is, first of all, physicians nowadays, they always want to do electronic, whatever you call it, prescriptions. You know, they don't do paper prescriptions, you know, not too many of them. And they want us to designate a primary pharmacy for them. Now, what is happening is that at the primary pharmacy, some of the drugs are coming out to be more expensive than at other pharmacies. And I'm trying to figure out how to avoid this kind of a situation where I have to go shopping every time I get a prescription. I have to go from pharmacy to pharmacy, and then I run into a problem where even though I go and show them my WellCare card, they say, well, we can't give you the cost till we run it through the system. Have you come up with anything that would help us decide what is the best way to minimize our out-of-pocket expense because of this quirk? And
Absolutely.
by the way, the WellCare website doesn't seem to help. I have written to them many times, and I've asked them for, you know, a simple app that I could go in and look, you know, put in the name of the medication and see where, you know, I could get the best price. So is there any solution to this, Dr. Patel?
Yeah, great question. So you're right, by the way, that the plan websites are typically very difficult to navigate. You know, we created a document which actually has direct links to all of the prior authorization and step therapy and formulary, because oftentimes no two sites look alike, right? And it's so hard to navigate where the information is. But to your question, that's part of what we do when we do the Medicare optimization, right? We are looking at under the pharmacy that you like to go to, and then we'll see, is it a preferred pharmacy or is it a standard network pharmacy? And then under each plan, there's actually a way that you can click on something which reveals all of the preferred pharmacies under that individual plan. And so we can identify, we can let you know, you're going to this pharmacy, this is what the cost would be. If you are open to going to this pharmacy, your cost would be lowered to this. And that way you can make a more informed decision as to where it makes the most sense to get your medications and what your cost would be.
But the problem is that, like I said, every medication is different. You know, the preferred pharmacies, we try and go to the preferred pharmacies. But for example, if I'm getting levothyroxine, it's better to go to Costco. You know, if I'm getting ketorolac, you know, I have to go to Ralph's or something like that. So how do I, you know, and besides, and I can't get the doctor to give me a paper prescription, you know, because he wants to do electronic.
Well, yeah, and starting January, just so you know, they all have to do electronic prescriptions. There won't be any more paper prescriptions in California. The point that you're making, there shouldn't be that cost variance for individual drugs at pharmacies unless you're at different phases of the benefit, right? Because if it's a preferred network pharmacy, the structure is such that tier 1 medications at a preferred pharmacy will cost X dollars, $3, let's say, and tier 2 medications will cost $5. So how much you should be expected to pay should be dependent on the tier of the medication. Now, if you're in the deductible phase, that's going to be different. But if you're otherwise, there should not be that variability in cost unless you reach the deductible phase, or if you're in the coverage gap and you have to pay 25% of the cost of the medications, and then it's based on the negotiated price between the pharmacy and the plan.
No, but not to belabor the point here, but just to give you an example, levothyroxine at Costco, I get it for zero copay. If I take levothyroxine to CVS, which is also a preferred network pharmacy, I'm charged $16, for the same medication. So it's a little disconcerting because it doesn't seem to be following any real guidelines, and
yeah, if I've never heard of a situation where two preferred pharmacies for the same medication can charge amounts that widely different. Actually, because it's not dependent. If they're for preferred pharmacies, then it's just dependent on the tier of the medication. That's how the structure is. So I would love to look at your particular situation in more detail.
Okay, I'll try and communicate with you individually.
Sure.
Thank you.
Of course.
If you have any questions, please ask them now.
Yeah.
Welcome, Satish ji.
Yeah. Question I have is that how these people are taking 4, 5, 6, 10 pills every day, how do they affect your gut health over a long time?
Yeah, I mean, it's a fair question, right? And especially a lot of these medications, they're hepatically metabolized and cleared by the kidney, and it depends. It depends on the medications. When we're going through the comprehensive med review, some of the things that we're looking for, in addition to adverse drug reactions, is we're looking for things like adverse effects. Are there side effects that individuals are complaining of? And can we attribute those to particular medications that they're taking or combinations of medications that they're taking? Are there medications that are potentially inappropriate for older adults? And if so, what are safer recommendations that we can make? So it's a great question. I can't give you an easy answer, but I can tell you that it's, part of that question is part of what we look at when we're doing the comprehensive med review.
Yeah, I have met you. I have come to your clinic this review once, and I would like to come again. The reason being, some of the medications which are particularly slow release over a period of time. If you take it in the morning, a 24-hour release, and because during the day you are mobile, you are working, all that could be easily consumed by the system, and nothing left in your system to create any side effect. On the other hand, if you have taken that very medicine after dinner, 8, 9, 10 o'clock, and you've gone to sleep, it has not metabolized, somehow still left, create your effect on your guts and create things such as constipation, other things there. This very dilemma, particularly I'm taking one medicine for BP, the literature says it will cause constipation. And I go to my PCP, he has no answer for me, what to do. He will give me something else that has another side effect. You keep on changing, it doesn't work.
Yeah.
Then I come up with this situation that if I take in the morning, I have less interaction for constipation side effect versus I take in the evening same time, metabolism, it says 24 hours, doesn't mean it will consume itself 24 hours. You're not giving it time to consume itself. It's staying in the gut they reacts with the system there, then causes impediment, effectively might become ineffective.
Yeah, no, I understand.
Anyway, some of my couple of cents here.
Yeah, no, I appreciate it.
Thank you, Satish ji, for that input. And if there are any questions, please ask them now. I know Simran has joined recently. And you and anyone who has any questions about Medicare Part D, please ask them now.
One thing I want to mention too real quickly is that, if you don't have Medicare, you can still come to this event. It's not like you have to show your Medicare card. So if you have family or friends that just want a review of their medications, or they just want some of the screenings or services, it's completely open to the public. This is specifically, these events are targeted to older adults predominantly. Others who have Medicare, people come to permanent disabilities, end-stage renal disease, but it's open to the community. So anyone can come and take advantage of these services. Just wanted to be clear about that.
So Dr. Patel, after the season is over, this Medicare enrollment is over, do you have any ongoing appointments or anything in your system where a person can make an appointment and get the medications reviewed?
So yeah, two things. One is after these, so if you come to the event, one of the things we give you is a little business card. It's called our healthcare passport. On that card is also our direct clinic phone number. So throughout the year, sometimes patients call because they're taking a new medication and they want to find out if it's covered by their drug plan, or they're taking new medications and they want to find out if there's a drug-drug interaction. So that's certainly one way. But the other way is you can just directly contact me. Over the course of the year, there are dozens and dozens of patients that do so, and I will help them as best I can.
That's excellent.
I see there are no more questions, but if there are any comments or suggestions, please go ahead and share that now. I myself would like to thank Dr. Patel for such an excellent presentation today and sharing the community resources, and for his community service. He has made this presentation available in just mere 2 days, just for our community, and spread the word and help everyone. So we really appreciate that, and we really very thankful to you, Dr. Patel, and it was an excellent presentation, very informative.
Thank you. Thank you
I
for the
would like-
opportunity, and thank you all for spending a little bit of your day with me.
Great.
Dhiren Bhai, would you like to close the meeting?
Yes. So thank you very much for spending your time with us. I'm sure you have a very busy schedule, very informative, and thank you very much.
Thank you, everyone. Take care.
Thank you, Dr. Patel.
Of course.
Bye-bye.